talking about the inhibitors of renin-angiotensin-aldosterone system or RAS, the antihypertensive effect, other beneficial effects, the precautions, contraindication, adverse effects and so on. For better understanding, please refer to my previous video on normal blood pressure regulatory mechanisms where I have discussed in details about the renin-angiotensin-aldosterone system. So moving on to give an overview of renin-angiotensin-aldosterone system, the figure drawn here shows the functioning of the renin-angiotensin-aldosterone system. So renin is secreted from the kidney and it causes conversion of angiotensinogen from the liver to angiotensin 1. Angiotensin 1, in presence of angiotensin converting enzyme, gets converted to angiotensin 2. The renin-angiotensin-aldosterone system is responsible for short-term regulation of blood pressure and is a normal homeostatic mechanism of our body, and it helps to control our blood pressure. But excessive or abnormal activity of the renin-angiotensin-aldosterone axis causes excessive formation of angiotensin 2 and increased concentration of angiotensin 2 through various mechanisms increases the peripheral vascular resistance, increases the cardiac output and thereby leads to chronic hypertension. So excessive activation of renin-angiotensin-aldosterone system leads to increased formation of angiotensin 2 and this leads to chronic hypertension. So the therapeutic goal is to reduce the formation of angiotensin 2 or to prevent the action of angiotensin 2 on the receptors that are expressed in various tissues such as heart, kidney, blood vessels and so on. So there are drugs that reduce the formation of angiotensin 2 and these drugs are known as ACE inhibitors and the drugs are enalapril, ramipril, captopril, lisinopril and quinapril. Also there are drugs that block the action of angiotensin 2 on various receptors. By blocking the action of angiotensin 2 on the various receptors, so these drugs prevent angiotensin 2 action and help in lowering blood pressure and these drugs are known as angiotensin receptor blockers. The drugs are losartan, telmisartan, valsartan, candesartan, olmesartan and so on. Then there is a drug that inhibits renin activity and the name of the drug is aliskiren. So aliskiren, by inhibiting the renin action, inhibits the renin-angiotensin-aldosterone axis and thereby helps in lowering the angiotensin 2 formation and decreasing angiotensin 2 action. So all of these drugs, ACE inhibitors, ARBs and renin inhibitors together comprise the RAS inhibitors and they inhibit the renin-angiotensin-aldosterone axis, decrease the formation of angiotensin 2, decrease angiotensin 2 action and help in lowering blood pressure by decreasing the peripheral vascular resistance and decreasing the cardiac output. So now let's see what are the mechanisms that are responsible for blood pressure lowering through reduced activity of angiotensin 2. So firstly, as we know that angiotensin 2 is a vasoconstrictor. By increasing the peripheral vascular resistance, it increases the blood pressure. So by reducing the angiotensin 2 action, it causes vasodilatation and a fall in blood pressure. Secondly, angiotensin 2 is a stimulator of aldosterone secretion from the adrenal cortex which causes increased reabsorption of sodium and water and potassium excretion. So because of reduced angiotensin 2 action, there is increased excretion of sodium and water and retention of potassium. Therefore, the ACE inhibitors and ARBs reduce the blood volume, the fluid volume in the body, decreasing the cardiac output, decreasing the blood pressure, but it retains potassium and causes hyperkalemia as a side effect because of retention of potassium and the increased excretion of sodium and water decreases the fluid volume and decreases the blood pressure. Also, angiotensin 2 is a stimulator of vasopressin secretion from the posterior pituitary, and as we know that vasopressin is an antidiuretic hormone. It retains water in the kidney and increases the fluid volume and increases the blood pressure. Also, vasopressin stimulates the thirst center and increases the water intake, increases the fluid volume. So, by reduced angiotensin 2 action, there is reduced vasopressin secretion, which causes increased excretion of sodium and water. There is reduced retention of sodium and water in the kidney, and also there is reduced water intake, and this helps in reducing the fluid volume and helps in lowering the blood pressure. So angiotensin 2 lowering helps in decreasing the aldosterone secretion, helps in decreasing the vasopressin secretion, and this decreases the fluid volume, the end diastolic volume, the stroke volume decreases, the cardiac output decreases, and the blood pressure decreases. Also, angiotensin 2 has direct action on the proximal tubules, and this is the site where there is increased reabsorption of sodium and water. By reduced angiotensin 2 action, there is increased excretion of sodium and water in the proximal tubular cells of the kidney, and this decreases the fluid volume and the cardiac output decreases. So angiotensin 2 through various mechanisms decrease the fluid volume, decrease the cardiac output, decrease the peripheral vascular resistance, and lowers the blood pressure. Also to be noted that the ACE enzyme, which is responsible for conversion of angiotensin 1 to angiotensin 2, is responsible for degradation of bradykinin. So ACE inhibitors which inhibit ACE enzyme also inhibits the degradation of bradykinin. So by inhibiting this enzyme, the bradykinin degradation is inhibited. This increases the concentration of bradykinin, and bradykinin is a potent vasodilator. It is an inflammatory mediator. It is a potent vasodilator, and this also contributes to the antihypertensive effect and cardioprotective actions. Therefore, in this way, the RAS inhibitors reduce angiotensin 2 formation, and this through various mechanisms helps in lowering the blood pressure by decreasing the peripheral vascular resistance and decreasing the cardiac output. The RAS inhibitors, particularly the ACE inhibitors and ARBs, are effective in all grades of hypertension and are widely used in the management of hypertension. There is no reflex tachycardia unlike nifedipine, which is a calcium channel blocker, which suddenly causes a fall in blood pressure, and there is reflex tachycardia as a result of compensatory sympathetic reflexes. So there is no reflex tachycardia unlike calcium channel blockers. Also, there is no rebound hypertension which is seen with beta blockers. So what is rebound hypertension? When the blood pressure is under control in presence of drug, that is a beta blocker, sudden discontinuation of the drug can cause a sharp rise in blood pressure. So ACE inhibitors and ARBs offers an advantage by not producing rebound hypertension. Postural hypertension is also not seen with ACE inhibitors and ARBs. The cardiovascular reflexes are not compromised and the responses to posture and exercise is not impaired. Thus, RAS inhibitors, including the ACE inhibitors and ARBs, do not cause reflex tachycardia. There is no rebound hypertension. Postural hypertension is not seen, so they are safe drugs in the management of hypertension. However, a precaution needs to be kept in mind that a sharp fall in blood pressure can be observed after starting the first dose. This is known as the first dose hypotension, and this is particularly seen in severely hypertensive patients on multi-drug regimes. Therefore, ACE inhibitors and ARBs are started with very small doses and increased gradually. There are some side effects associated with ACE inhibitors and ARBs, and these are hyperkalemia, that is raised potassium level in the body, and this is due to retention of potassium in the body in exchange for sodium and water. So high potassium level can lead to cardiovascular events, particularly in elderly patients and those who are taking potassium supplements. Also, cough is a side effect of ACE inhibitor. Remember, we have discussed ACE enzyme is responsible for the degradation of bradykinin. So by inhibiting the ACE enzyme, the bradykinin levels are increased and it is a inflammatory mediator, and this is responsible for cough production. So if the patient experiences cough as a side effect of ACE inhibitor, dose reduction or switching to another ACE inhibitor is not effective. So in such situation, the ACE inhibitor needs to be substituted by an angiotensin receptor blocker which lacks side effects such as cough and angioedema. Also, angioedema occur because of raised bradykinin levels with ACE inhibitor. So discontinuing the ACE inhibitor and treating angioedema with H1 antihistaminics and corticosteroids is recommended. There are other side effects such as loss of taste and headache, dizziness. So there are important contraindications to the use of ACE inhibitors and ARBs. The ACE inhibitors and ARBs are contraindicated in bilateral renal artery stenosis. So in bilateral renal artery stenosis, the renal blood flow is severely compromised, is drastically reduced due to reduced blood supply to the kidney. Due to reduced renal blood flow to the kidney, the glomerular filtration rate decreases, and severe reduction in glomerular filtration rate can lead to acute renal failure. So in such a situation, angiotensin 2 action can be protective to the kidney. So endogenous angiotensin 2 causes constriction of the efferent arteriole. So it has no action on the afferent arteriole, but it constricts the efferent arteriole, and by constricting or narrowing the efferent arteriole, it increases the pressure in the glomerulus. So the glomerular filtration pressure increases, and this helps to maintain the glomerular filtration rate. So angiotensin 2, by causing constriction of the efferent arteriole, and it increases the glomerular filtration rate, helps to maintain the glomerular perfusion pressure, and this prevents renal failure. By using angiotensin 2 inhibitors, angiotensin 2 formation is reduced and angiotensin 2 action is blocked. So by blocking angiotensin 2 action, the glomerular filtration rate decreases, and this can lead to renal failure. So the protective action of angiotensin 2 is blocked by using ACE inhibitors, and therefore ACE inhibitors are contraindicated in bilateral renal artery stenosis or unilateral renal artery stenosis with a single kidney. The second contraindication of ACE inhibitors is pregnancy. So ACE inhibitors and ARBs are known to cause fetal toxicity in animals, and therefore these drugs should be avoided in pregnancy. So ACE inhibitors should not be administered in a pregnant woman. Next is combination therapy. In the management of hypertension, combination therapy is preferred. ACE inhibitor or ARB can be combined with the thiazide diuretic, and the advantage of combining with the thiazide diuretic is that thiazide diuretic possesses the property of potentiation, which means that thiazide diuretic, when combined with another antihypertensive agent, potentiates or enhances the antihypertensive effect. So the effectiveness of the drug or the regimen is increased. Also, the combination reduces the side effects that are induced by thiazide diuretics. For example, hypokalemia, hyperglycemia, hypercholesterolemia, hyperuricemia is reduced by the addition of ACE inhibitors and ARBs. So combination therapy increases the efficacy and reduces the side effect. The effectiveness of the regimen is increased and the safety profile is increased. We have learned the mechanisms that are responsible for the antihypertensive effect of ACE inhibitors and ARBs, the precautions, contraindications, side effects, the advantages of combination therapy.